Surgeon at Pro Ortho here in Kirkland. Thank everyone for joining me this evening on a nice day here in the Seattle area. We're just going to go through a little talk here, sponsored by IRG, regarding meniscus tears. So we'll get started here, as I think we're about 6 o'clock, and appreciate everyone taking the time to join. So we're going to go through meniscus tears and just kind of take a big look and an overview at meniscus tears. We'll get as in-depth as we feel like getting with questions that come in. We have a mixed audience here today of physical therapists, but also some folks in the community who may be having some of these problems. A little bit of background about me: I'm a board certified orthopedic surgeon, fellowship trained in sports medicine. I've been practicing in the Seattle area for about 13 years after training and doing my residency at the University of Washington, and then doing a sports medicine fellowship in Palo Alto with Dr. Warren King. So a lot of my practice is based around sports injuries, but also degenerative wear and tear problems of the knee, and meniscus tears would definitely fall under that category often. So just to go through any disclosures, I have no conflicts of interest or financial conflicts to disclose for this talk. And so what we're going to try to go through here in the next 20 or 30 minutes or so is looking at meniscus tears and how they present to us in the office, and looking at some of the basic anatomy of the knee joint itself. Then we'll dive a little bit deeper into looking at the meniscus structure itself and some of the specific anatomy with the meniscus. And then we'll look at how that plays a role in the function of the meniscus and the meniscus's job in the knee. Then we'll get into some of the clinical presentation of meniscus tears and how they show up and how people experience them and how we make that diagnosis. And then we'll look at the treatment of those, and part of that will be based upon the types of meniscus tears that we see in the knee, and that will drive some of the specific treatment options. So just a little overview of this problem. It's a very common problem in the knee. It's the number one reason that people come to see the orthopedic surgeon with respect to knee problems, and about 12 to 14% of problems that show up to an orthopedic surgeon with respect to the knee are going to be diagnosed as meniscus tears. It's estimated that 60 to 70 out of 100,000 people in this country have a meniscus tear. And this is the most common surgery performed by orthopedic surgeons in the country. So meniscus tears can come in a couple different categories typically that we will see. We'll see those that show up as an acute onset of knee pain after a distinct injury, and we would think of those as traumatic tears. And then there's very commonly people who present with no particular story or reason that the meniscus or the knee started to hurt them, and that can be a gradual wear and tear type of problem, and those are classified as degenerative tears. So common symptoms that people will experience with the meniscus tear is pain that localizes to one side of the knee or the other, known as the medial or the lateral joint line of the knee. Often there's going to be swelling associated with this problem, and less commonly, but fairly classically, people can describe a catching or locking sensation in their knee, or the feeling of something moving out of place and then occasionally can move back into place if they manipulate or twist the knee. So we'll back up and kind of start with the basic anatomy here and structure, and looking at, well, what is the meniscus itself? And so this is essentially a crescent-shaped wedge that is positioned between our thigh bone or the femur and the shin bone, which is known as the tibia. And so when we walk or stand or run, these bones are in contact with one another, and the meniscus helps the shape of the round thigh bone fit better on the flat surface of our shin bone to slow down wear and tear of the cartilage cap that's on the end of the bones. So if we take a look at the diagram here of the thigh bone or the femur, we can see there's this white thin layer, and that's the surface cartilage which coats the bone. And the top of our shin bone or tibia also has a similar surface, and the meniscus would be in between there as a C-shaped structure, helping to cushion that. And the way it really works is by creating a larger contact area between those surfaces to spread out the pressure and slow down the wear and tear. As we load or walk on our knee, we have a compressive force across our knee, and due to the structures of the fibers in the meniscus, it will actually convert that into more of what we call a hoop stress and act as a shock absorber that way. The bottom line is having that meniscus in there will help prevent or slow down arthritis. So looking at some of the anatomy of the meniscus itself, we can see from the top view looking down, the medial meniscus here on the inside and the lateral meniscus on the outside portion of the knee. We can see that their size is different and that the medial meniscus will be longer with this lateral side being shorter, but it often tends to be wider. You can see that some of the dimensions there on the slide. And we think of this meniscus as having three distinct areas, although they flow into one another, but the way we describe them are by their horns. The anterior horns are in the front portion. The middle third we refer to as the body of the meniscus, and the back third is called the posterior horn. They attach down to the shin bone through their root attachments. At the front, this is the anterior root, and in the back, the posterior root attachments. The meniscus is also firmly attached to the periphery or the outside of our knee joint through the capsule, and the lateral meniscus also attaches to the thigh bone or femur through a ligament that runs with the PCL. Importantly, the inner edge of this meniscus is freely mobile. So when I go into a knee with a scope and feel with a probe, I can get underneath that free edge and that edge can move. And that has some consequences with respect to what happens when we tear our meniscus and some of the symptoms we get. So important in understanding the meniscus and why it tears and why it doesn't fix itself throughout life and why not all meniscus tears can be repaired is that the meniscus has a very poor blood supply. So most of our meniscus does not have any blood vessels as we reach adulthood. When we're younger and developing, we have a greater amount of blood flow, but basically by the time we're 10, very little of our meniscus has blood supply. So you can see in this diagram here that the blood flow to the meniscus comes in from the blood vessels that are in the lining around our knee joint called the capsule and the very fine lining tissue that's inside our joint called the synovium. And little blood vessels grow in from the side of that, but they only penetrate about 10 to 30% of the way into the meniscus. And that, of course, would have implications on the ability of something to heal. If there's no blood flow there, then the body can't deliver what it needs to repair things. So when we look at the meniscus, we break it down into zones based on those blood flow areas. So the area around the periphery of the meniscus that has blood vessels in it, we refer to as the red zone. The inner portion that has no blood vessels, we refer to as the white zone. And where there's an intermediate zone where we have qualities of both and where those are mixing or meeting, we refer to that as the white-red zone. Looking further at some of the anatomy of that meniscus, the meniscus is a complex structure that's made up mostly of water, as you can see, and there's some organic material, some of which helps hold that, but the majority of which is fibers known as collagen. And so we have different types of collagen in our body. Most of the meniscus is made up of something called type 1 collagen. And if we look at the structure of this meniscus, you can see that different layers of the meniscus have different orientation of the collagen. On the superficial layer, this is quite random. As we get down to the deep layer, importantly, we have these fibers that run the direction of the meniscus in a circumferential fashion, and that has a large role with respect to the hoop-like structure of the meniscus and how it absorbs shock. So to review the function of the meniscus that we touched upon a little bit earlier, the meniscus serves as a load-bearing structure, helps with shock absorption in our knee. By its shape and by cradling the round surface of our thigh bone on the flat surface of our shin bone, it plays a role in joint stability working along with the ligaments. There's also some role in position sense, or what's known as proprioception, which is the ability for our body to tell where different parts are in space. And it's been shown that it possibly also helps with lubrication of the joint. So when we look at the load absorption or load-bearing function of our meniscus, you can see that looking at the medial compartment, we know that 50% of the loads of the medial compartment of our knee or the inside part of our knee is actually absorbed by the meniscus. And in the lateral side of our knee or the outside compartment, this actually goes up to 70%. And it actually varies depending on the degree of knee bending. In full flexion or in full knee bending of our knee, our lateral meniscus takes 100% of the load across the knee joint. So loss of our meniscus has been shown in studies, of course, to decrease the contact area by up to 50 or 70%, and that increases the amount of pressure seen across the cartilage in that part of the knee. And so the result of losing meniscus or having meniscus deficiency is to have higher pressures occur in the knee over a smaller area of cartilage, which over time will lead to osteoarthritis or loss of the surface cartilage. So here's a few diagrams to illustrate that point. So this is an X-ray of the knee taken from a side view or lateral view. And so this is typically what we would see on an X-ray, which doesn't show the meniscus or the soft tissue. But if you think of the knee not having a meniscus here, you can see by the shape of that thigh bone on top of a fairly flat surface of our shin bone that all the pressure would be taken right at that point, and that would be a very high load over a small area. In this diagram here, the artist has drawn in sort of the shape of the meniscus there to cup and fill in those gaps, if you were to look at it that way, which increases the area in contact over a much larger area. So to look at it as a stress diagram over here, we can see this represents the femur, the thigh bone surface on top of the flat shin bone surface. And by having the meniscus in here, we spread out that contact area. And so this diagram here shows a larger area under contact, and the pressures, the peak pressures, don't go as high as this situation here where we have a small area under contact and these peak forces or pressures are very high. So how do meniscus tears actually present in patients? Typically, the main complaint is of pain located at a joint line, so either on the inside or outside part of the knee. As I mentioned earlier, this will often be accompanied by swelling, sometimes after an acute injury, but sometimes this can be intermittent depending on activity level. Often the pain will be described as a sharp pain, worse with planting and twisting activities or side-to-side movements. And classically, in all our medical textbooks, we read about locking up of the knee, where the knee gets stuck in a certain position and is unable to be straightened or fully bent. This is less common, but certainly when it happens is fairly classic for a meniscus tear. As I mentioned early on, we sort of group meniscus tears into two categories overall when we look at how to approach them. The first being a traumatic type of tear, where again, there's a clear story of an injury or onset there, typically a twisting or squatting type of injury. This is often seen in younger patients under 40 years old and is often accompanied by a ligament injury as well. Commonly an ACL tear has been reported sometimes in 80% of meniscus tears in younger patients. More often in the office, we probably see folks who come in with degenerative tears of the meniscus. And so this is the other category where there's not necessarily a clear injury, but folks can just wake up sometimes with pain in the knee or after a minor event. And this is because our meniscus does break down over time. And some of that is based on the lack of blood flow. So we simply accumulate the wear and tear and damage throughout our life in the meniscus and undergo some degenerative changes. We can also see this in younger patients if they've had an unstable knee for a long period of time due to a chronic ligament injury like an ACL tear, then that meniscus will look degenerative and have more characteristics of a wear and tear type of situation. And we can also get to this situation earlier in life in folks who have a lot of what we call malalignment of the knee, where there's excessive bow-leggedness or knock-kneed alignment, putting more stress on that knee earlier in life. So the diagnosis of a meniscus tear can often be made in the office simply by listening to the history, what are the symptoms and what does the patient feel, and then often by physical examination. So physical examination findings that are most commonly seen are tenderness to the touch or palpation along the side of the joint or the joint line where the meniscus is torn. So in the office, you can see the diagram here. The examiner will walk their fingers along this joint line where the thigh bone and shin bone meet, and often that can be very tender, and that can be experienced in life by folks as complaining of pain when you lie on your side sleeping and the knees are touching one another. In the office, we also look for swelling or what's called a joint effusion. And a joint effusion is the overproduction of the normal joint fluid that lubricates our joint. So when there's an irritant causing inflammation inside the knee will often overproduce this fluid, and we can see that on examination as an effusion, and that will be experienced as the feeling of stiffness or tightness by the patient. We'll often see a loss of range of motion of the knee where the knee won't fully bend or fully straighten. And that will be more common when there's an unstable type of meniscus where there may be part of the meniscus blocking the motion to the knee. And then there's a series of special meniscus tests that have been developed over the decades to try and diagnose a meniscus tear. And some of these come from pre-MRI, where there was no ability to obtain other imaging to confirm this. So here are three of the classic examination maneuvers that we'll perform in the office to evaluate for a meniscus tear. So there's a test called the McMurray's test, where we flex and load the knee and then bring it back into extension while rotating. And the idea is if we're causing a pinching or catching of a torn meniscus, that will cause a clunking sensation and pain. Similarly, this can be done by turning a patient over on their stomach and performing what's called an Apley compression test. I wouldn't recommend putting your knee on the back of a patient's thigh, as that probably won't be appreciated too much, but that can be done without kneeling on the knee, as the diagram shows here. And then there's a Thessaly test, where we have a patient stand and perform a little mini squat to about 30 degrees, standing on the knee that hurts, and then perform some rotation maneuvers side to side. And that will often reproduce the pain, and that's actually been shown out of those three tests to be the most sensitive in picking up a torn meniscus. So nowadays, of course, most of us will confirm the diagnosis before any further treatment with an MRI. The first thing that'll be done typically in the office before getting an MRI is to get a weight-bearing or standing X-ray. And that's a very important step to rule out severe arthritis or significant arthritis as the cause of the pain or symptoms, which will really look very similar as far as the pain and the symptoms that a patient will experience. So if the weight-bearing X-rays don't show much in the way of arthritis, then we'll typically move on when it's appropriate to get an MRI to confirm the suspicion of a torn meniscus. And so in this image here, this is a straight ahead view MRI of a patient. And so we see the thigh bone or the femur on the top. The shin bone is down below here. And the meniscus cartilage with this type of MRI should show up as a dark triangular structure in this cross section. So this is the normal location and normal appearance of the medial meniscus on the inside part of the knee. But if we take a look over at the lateral side, we sort of see a ghost of the meniscus here, but we don't really see the normal meniscus structure, because in this patient, it's actually flipped and displaced here into the center of the knee. And this is what's known as a bucket handle tear, where this meniscus has flipped in and gotten stuck in this patient's knee. So further ways we describe the meniscus on top of the acute versus degenerative are by the location of the tear. As we looked at the anatomy before, we'll describe it as a posterior horn, a body, or an anterior horn tear. And some meniscus tears, of course, can extend through multiple zones or be trizonal in nature. And then we'll describe it based on the location as far as the depth into the meniscus and the relationship to the blood flow there. And that's where we look at our red or white or our red-white zone tears. Now we'll look also at the structure of the meniscus and the direction of the tear and how we describe it there. So we'll look at the tear direction and the tear characteristic, and there are certain fairly classic meniscus tears there, and we'll go through this in some of the diagrams. We have longitudinal tears, which are a vertical type of tear in the meniscus. We have radial tears of the meniscus, where the tear goes into the meniscus in the direction of a bicycle spoke, if we think of it like a circle. Then there can be flap tears that we refer to as parrot beak tears. There are horizontal tears where the tear is parallel to the upper surface of the shin bone or the plane of the joint. And then we have these bucket handle tears, as I mentioned earlier, which is a type of a longitudinal or vertical tear where the tear is so big that the piece can flip into the middle of the knee on a hinge like a bucket handle. And then we have a special category known as root tears, where the meniscus is actually torn from its anchor point to the bone. And this has been recognized more and more in the last decade or so. So here's a diagram looking at some of those tears, and we have our zones of the meniscus above. If we look at the tear characteristics here, this is a longitudinal tear, which is running along this axis here of the meniscus. And again, it's a vertical type of tear, as if someone cut from up to down through this meniscus. When we see this come in the inner surface and take a turn here, we refer to this as an oblique tear. If this gets big enough, it creates a flap, almost like a mouth, and we call that a parrot beak tear. On the other meniscus here, we have a radial tear, again, which is a direction going in straight like a bicycle spoke, very common in the middle third or the body of the lateral meniscus. This 3D diagram shows, again, some of those tears where we have a parrot beak tear. And this shows a little bit better this horizontal tear, which will go in and create an upper deck and a lower deck to the meniscus, which isn't necessarily unstable. At the outer rim of the meniscus, this would exit as a horizontal tear. And this inlay diagram shows a bucket handle tear where you can see that this is a longitudinal tear that still is attached at the front and the back, but can take a shortcut through the middle of the knee by flipping or just running straight through the knee. So again, to understand that bucket handle tear here in the diagram form, we have hinges here similar to a bucket, and this can flip over into the middle of the knee. So here's an arthroscopic series of photographs of a bucket handle tear. So we're looking in the center of this patient's knee. This is the end of the thigh bone with the cartilage. This is the shin bone surface with cartilage. And the meniscus in this case should be running from the front around the periphery here, but instead it's taking a shortcut through the center of the knee. So as we pull out with our scope, we can see this large bucket handle fragment and the native meniscus where it should be, where it came from. So this is the back half of the meniscus actually flipped forward into the front of the knee and seen here after it's pushed back to some degree. So now let's look at treatment of the meniscus tears and how we look at those decisions. So not all meniscus tears require surgery. We look at non-surgical versus surgical treatment options of the meniscus tear, and there's various characteristics and different situations which will drive which one is best for each patient, at least as an initial approach. So if we look at the different factors that affect that, primarily we look at the characteristics of that meniscus and decide, is that meniscus tear unstable or is it stable? And what that means is mechanically, does that meniscus pop in and out of a good and bad portion of the knee, or is it really expected to stay where the meniscus is supposed to be and simply be a problem that the meniscus is broken and maybe not doing its job as well? We also look, of course, at the age of the patient and their overall health and what their activity level is to look at what are the demands on this knee, what are the expectations, and what is the ability of a patient to rehabilitate the knee or even go through surgery successfully and safely. Another factor in determining what the initial steps would be is how long has the problem been going on. So of course, we look at a situation where someone has been having knee pain for 6 days differently than someone who's had knee pain for 6 months as far as what the next step may be. Often for a shorter duration, we're going to, of course, look at non-surgical management to see if some rest or time or other non-surgical or non-invasive treatments can do the job. Along with that, of course, would be, well, what treatments have been tried? So we look at treatment to date, and if there's been no treatment or trial of previous treatment like physical therapy in the appropriate tear, then certainly that would be the first step. And of course, another factor would be what other injuries exist in the knee. So as I mentioned earlier, often we can see a meniscus tear with a ligament injury. Something's popping up here. Let me close this down. And that treatment of the meniscus injury or the ACL injury or ligament injury would often drive the meniscus to be treated at the same time in a tear that may not otherwise warrant aggressive or surgical management. So in general, the way we think about this is in a stable meniscus, degenerative type of situation, we will usually treat this non-operatively. And for an unstable tear, we're going to consider surgery. Another factor in considering surgery is the tear a repairable type of tear? So if we have the ability to try to preserve the meniscus by doing a surgical repair, that will often lead us to go to surgery rather than allowing that meniscus to deteriorate further and become non-repairable, and that would lead to meniscus trimming, which may lead to arthritis. So for non-surgical management, this is typically recommended, as I mentioned, for first-line treatment for degenerative or stable type of tears. Typically, this can be seen in an older patient, certainly 50 years or older with lower energy or non-traumatic type of problem. Or if we look at a tear and it seems that surgical repair is not appropriate, or that surgical cleanup is not necessarily going to make the situation better. And so non-surgical management would consist of rest and ice, modifying activities, which may mean staying away from offending activities like squatting or twisting activities. And this is often coupled with physical therapy to help strengthen the muscles around the knee. So if we have a compromised meniscus in the knee and the problem is really that the shock absorber is not working as well, and then the stabilizer is not working as well, we know that strengthening the muscles around the knee to serve as a shock absorber and to help with stability can often help eliminate or minimize the symptoms in the knee. And there's been several studies that have looked at degenerative tears in the meniscus and looked at patients a year after they were diagnosed and found that those patients who had physical therapy were just as happy as the patients who had surgical trimming or cleanup of the meniscus tear. When we look at surgical management of meniscus tear, the surgery really falls into two different categories of what will be done. One of these would be a partial meniscectomy, which is simply to clean up the torn flap of meniscus and remove it, and the other would be a repair. So if we look at a partial meniscectomy, this is an arthroscopic surgery, which means it's a surgery done through some small poke hole incisions in the front of the knee. And the goal of that is to go in with small biters and shavers and to remove the torn, unstable portion of the meniscus, leaving as much healthy, stable meniscus behind. This can be a surgery with a very quick recovery where patients can get back to activities within several weeks, but the downside of it can be permanent loss of some of the meniscus, which can have consequences of leading to increased wear and tear in that part of the knee and arthritis. Meniscus repair is often done in an all arthroscopic fashion as well, so the incisions can be similar with no additional incisions made. The goal of a meniscus repair is to put the torn meniscus back together and repair that meniscus and see if we can get the body to heal the meniscus, which, as we talked about, can be a challenging thing because of the lack of blood flow to much of the meniscus. But when we go into a knee and I go in there surgically, a repair will typically be performed if it looks like that meniscus has the capacity to heal, and that's appropriate. And if a patient is willing to perform the slower rehabilitation that goes along with the repaired meniscus compared to the trimming of the meniscus. And we look at those factors that determine healing potential as far as location of the tear and patient's age to determine whether this has an opportunity to heal. The benefit of the meniscus repair is that it's meniscus preserving, and that decreases the risk of arthritis in the future. So here we'll take a look at partial meniscectomy. So this is essentially the setup in the operating room where there's instrumentation coming in through two poke hole incisions in the knee. There's a scope coming into the knee with a camera, and we can look at that on a screen while doing the surgery. And in this case, there's a shaver device in the left hand of the surgeon, and that can be used to clean up the meniscus. So we'll see if we can get the surgical video here to play. And so this is a surgical video of a patient of mine undergoing a partial medial meniscectomy. So you can see that the probe came in and identified a flap of meniscus there in the back. I then bring in an arthroscopic shaver, which is controlled with a foot pedal that can remove the flap by having some oscillating jaws that can trim the tissue. And there's a suction device attached to this, which will pull the diseased tissue into those jaws. So while opening up the knee joint, we simply go back and debride those flaps, which means removing the torn flaps of tissue and try to smooth out that meniscus as much as possible. And this procedure is all done by inflating the knee with some fluid. So this essentially is being done under fluid or underwater, so you can see some things floating by occasionally. And the reason we're not seeing bleeding is that the pressure of the fluid in the knee is kept just above the blood vessel pressure in the knee, and that stops blood most of the time from coming into that fluid, so we can get a very nice clear picture. So now you can see it looks like there's an additional flap there that I can find, and with probe, go back and find that area, and sure enough, in this patient, there was quite a large flap of meniscus that was flipped up and tucked and wedged between the thigh bone and the meniscus, and that typically will cause a large amount of pain. So now I come in with an arthroscopic biter, which is a sharp biting device, and I can just trim the remaining stalk where that flap of meniscus is attached to the normal meniscus. And in this case, because it is such a large piece, rather than using the shaver, I can reach in with a grasper device and take that piece out of the knee as one large piece. You can see there's still some debris left behind. And so the next step will be to introduce the shaver again, and just to clean up any debris that's left behind and smooth the edges of the meniscus to try and prevent any tags or weak spots there where the meniscus may tear in the future. And again, you can see using these small instruments that we're able to get way to the back of the knee, and I'm opening this patient's knee up by applying stress there to minimize any injury to the cartilage surfaces. So then the other option, as I mentioned, is meniscus repair. And so here are some diagrams and a surgical photograph of meniscus repair. So as I mentioned, largely we can perform these procedures with an all arthroscopic technique. So that means we're making two poke holes in the front of the knee and introducing a needle with suture on special arthroscopic devices. And so the needle can puncture across the tear and deliver these little plastic buttons to the back side of the meniscus that are attached to suture or stitches. And then these can be tensioned down and sutured down to close down a longitudinal or vertical tear, in this case, leading to a secure repair across that meniscus. And you can see that this meniscus was a suitable one for repair as it's near the outside or periphery of that meniscus in this red zone. You can see the red that we talk about coming from the capsule of the meniscus. So this is where the blood flow comes from into the meniscus and would have the ability to penetrate into this zone and help this heal. So when we look at the different types of surgery and the recovery that entails, when we do a cleanup type of surgery or partial meniscectomy, because nothing needs to heal with that operation, patients can weight bear as tolerated right away. And typically that will mean using crutches or a cane or a walking pole for at least 1 or 2 days until feeling more stable on the knee. But many patients use no crutches. I would say about half of my patients report that they didn't require the crutches at all. Starting off right away with range of motion as tolerated. So we use a home exercise program, and typically formal physical therapy isn't needed. I provide patients with a self-directed rehab program, and patients can just progress based on pain and swelling gradually over a 4 to 6 week period. So generally that's going to entail some low impact activities for the first week, maybe walking outside the house around the block. Usually we can get some stationary bike going by the second week. Week 3 and 4 can be things like the elliptical machine and some basic strengthening exercises, and then reserving return to running or impact activities in sports for 4 to 6 weeks, just depending on individual recovery. Looking at a meniscus repair, that's a much slower and more deliberate rehab because now we're repairing tissue and we need to protect that tissue to allow it to have time to heal. So that will typically entail using crutches for a period of 4 to 6 weeks and using what we call toe touch weight bearing, which simply means not putting body weight down on the affected leg. I'll also put patients in a brace to limit the range of motion or the bending of the knee, typically from 0 to 90 degrees during that same time period. As we know, with increased bending of the knee, we see motion of the meniscus, and that can stress the repair and lead to non-healing of the repair. And then we want to further protect it, even though weight bearing has started and walking has started, by avoiding any squatting deeper than 90 degrees during that first 3-month period. So strengthening can be comprised of mini squats or more shallow squats and leg press, but avoiding deep body weight squats. After 3 months of healing time, we generally will start some running or impact activities, but really avoid shearing activities with cutting and jumping for the first 4 to 5 months after meniscus repair surgery. So the outcomes of both of these surgeries are typically very good. With partial meniscectomy, that's typically one of the highest satisfaction rates that we have in orthopedic surgery. So for a fairly simple and quick procedure that takes 15 minutes, it can really be a lifestyle changer. Patients with unstable tears of the meniscus will often notice immediately, even on the day of surgery, after walking on that knee, that the knee feels better. There can be pain with surgery or soreness, but the pain is different. And often the change is immediate. The surgery has a very low complication rate due to the arthroscopic and very minimally invasive nature and the short duration of the surgery. And when we do see patients who do struggle or have some poor outcomes, it's typically because of the amount of arthritis that's there in the knee, in addition to the meniscus tear. So this is where patient selection on who we think can get better with a knee scope surgery and clean up the meniscus versus who probably isn't is really key to having patients who are satisfied with the operation versus those who really we don't change the outcome. When we look at meniscus repair, historically, studies have looked at how often these heal or don't heal, and the non-healing rate of meniscus repair surgery is typically around 15% or so. Of course, the decision on which meniscus to repair or not is going to affect that rate. And so if we stick to repairing tears that are more favorable and have a chance to heal, we're going to have a higher healing rate. But certainly recently, with the appreciation of preserving the meniscus, we try to be as aggressive as possible trying to preserve the meniscus there and performing tears, even understanding that 1 in 5 of them may not heal. And that may require another minor surgery to go in and do the trimming of the meniscus to relieve the pain. But meniscus repair, similar to partial meniscectomy, has a very low complication rate. There's a little higher risk of injury to structures in the back of the knee due to passing needles there to pass sutures and some of those techniques. But again, the complication rate is quite low. So as I mentioned, some of the current trends that we are looking at in meniscus tears is really towards meniscus preservation. And this comes with understanding the consequences of previous treatment mechanisms of meniscus tears. So up until about 1982, most meniscus tears were treated with a total meniscectomy, which meant removing the whole meniscus. And there was actually the thought in athletic patients that if you remove that whole meniscus, that's going to be great because now we save them from tearing that meniscus again. And it was discovered over time that in about 10 to 15 years, those patients who had a total meniscus removal had pretty significant arthritis on x-rays, which became lifestyle limiting. So we're really much more aggressive about trying to preserve the meniscus and doing repairs on tears that historically maybe were thought to not be able to heal or to be irreparable. And some of that change has come from our understanding of the consequence of trimming the meniscus, and some of it has come because we have some tools now to repair tears in certain directions that we couldn't fix before. And so typically tears that were horizontal in nature or radial tears, we didn't really have a good way to fix those. We had good ways to fix those longitudinal tears. But recently we have devices similar to what's shown here to be able to pass a needle within the tight space of the back of the knee in a vertical fashion. So we're able to take a bite of the meniscus in the jaws, and then the device can pass a suture with a needle in a vertical direction. So I can actually take a bite of this meniscus and perform a side-to-side type of repair of a tear that may run into this meniscus in this direction. The other trend that we're seeing is to try and increase healing rates by trying to control the biology in the knee. So a major factor of non-healing of the meniscus is the lack of blood flow, as I mentioned earlier. So several studies have looked at trying to augment or improve the healing using some biologic factors such as PRP, which can be taken from blood in our body or other tissues such as stem cells. So if we take a look at that in the current literature, this has been investigated. To date, there are no studies that show consistent benefit of using these augmentation techniques across all meniscus repairs. And what PRP is something that's called platelet-rich plasma, where we draw blood from a patient's arm, and then we can spin this down and concentrate a portion of the blood into plasma that is rich in cells called platelets. And platelets contain growth factors and other things that can stimulate a healing response. And so it makes sense that if we take an area that doesn't have much in the way of nutrition or blood flow and add some of these factors, that we may be able to see a higher healing rate. It's something that I have used in my practice, but again, there's not a large body of literature to support it over not using it. Certainly we know that it's not harmful in this setting and may help. So in summary, if we talk about meniscus tears overall, we know this is a very, very common cause of knee pain in both adult and adolescent populations. We see two general populations who experience this problem, one of them being a younger population with an acute injury that fall into the traumatic category, and then another population who is more of an accumulative wear and tear over time in the degenerative tear category. The symptoms that are classic for meniscus tear would be pain that localizes to the inside or outside part of the knee, often with swelling and occasionally with some walking up symptoms in the knee. When we look at tear patterns overall, in the most basic way of thinking about it and directing our treatment, we think of them as stable tears that are not causing any mechanical catching or irritation, or unstable tears that are causing potentially mechanical irritation in the knee. When we look at driving our treatment, the stability of the tear, as well as the type of the tear, and patient factors such as age and patient profile, which would include what they do for a living and for recreation, will drive the initial treatment between non-surgical and surgical treatment options, as well as duration of symptoms, as I mentioned earlier. In general, when we look at degenerative tears that are stable, these are treated without surgery. And when we look at unstable tears, these are generally going to be treated surgically for the best outcome. And again, the importance of meniscus preservation has really been stressed over the past decade, and that's where we're looking at meniscus preservation, certainly, and even potentially augmentation or replacement type of options, which is a little bit beyond our spectrum today, but as sort of the next wave when folks can't have their meniscus preserved. And really overall, meniscus surgery is a relatively quick, straightforward procedure in most hands. It has excellent outcomes and excellent patient satisfaction in getting folks back to the things they like to do. So I'd like to thank everyone for taking their time this evening to learn a little bit more about meniscus tears, and happy to take any questions that folks might have.